Good afternoon, respected chair and dear delegates. Myself, Dr. Mohsin. I am a consultant urologist from Guntur, Andhra Pradesh. So the talk was allotted to me is asymptomatic large prostate. The talk is whether to treat or not is the main idea of my talk. Enlarged prostates are usually the incidental detections on ultrasound done recent days due to master checkups and or general physician or general surgical colleagues who does ultrasound for some other reason may found some prostate and they'll refer to us. So 25, 30 grams, 40 grams prostate, they'll refer to us. And sometimes there might be incidental finding during cross-sectional studies like CT scan, MRI done for some other pathology. And what is large prostate? Actually, the size of the prostate, there are several classifications or various opinions are there. Regarding medical opinion, more than 30 or 40 grams of prostate is considered as large prostate, medical group. In view of surgical criteria, more than 80 grams prostate is considered as large. But here, hence my topic is incidental detection. Usually on ultrasound, I have chosen I have taken a classification from a French journal. So, as we all aware that normal prostate ranges from 15 to 20 cc and 30 to 40 cc is a small prostate, 40 to 80 cc is a medium sized prostate and more than 80 cc is a large prostate. So, enlarged prostate may have a variety of presentation, variety of symptoms or no symptoms at all. Patients with a large prostate sometimes may be asymptomatic also. So patients who are having a large prostate and they will present to us clinic with lower urinary tract symptoms, and we are not going to discuss about this. Our subject is a patient who present to us on an incidental finding on ultrasound. Most commonly is ultrasound, and we need to assess him by IPSS symptom score, physical examination, and digital rectal examination is a vital component to assess the size, DRE, and complete urine examination to assess the renal functions, to assess the post-vital residual urine, and uroflowmetry to see whether it's a bell-shaped curve or any obstructive pattern in the curve. And serum PSA is an optional test, should be done after shared decision making with the patient. And we are all aware of LUTs, avoiding LUTs, storage LUTs, and post-maturation symptoms. And IPSS score is an essential key tool in assessing the patient to classify symptoms as a mild, moderate or severe, and is important in the criteria for management. Men with large prostates are increased risk of developing both for LUTs as well as retention, whether acute or chronic. And veteran affairs cohort showed men with a prostate over 30 cc in the volume were 3 times more likely to develop acute urinary retention. The Armstead County study showed that men with a prostate over 50 cc in the volume were 3.5 times more likely to develop moderate to severe LUTs. Veteran affairs cohort and Armstead study cohort, they did study of the prostate ranging from 36 to 55 cc, whereas the PLUS study, the mean prostate volume is 82 cc, which I will discuss in my next slides. A study by Barry and colleagues showed there is a little correlation between prostate volume and severity of the LUTs. And a study from the Gilman and colleagues in a cohort of men aged 40 to 80 years living in Armstead County, so demonstrated little correlation between the severity of the LUTs and the prostate volume. Now, the Armstead County study, which shows that prostate more than 50 cc are 3 times more likely to develop LUTs compared to the size small prostates, and this shows that the size of the LUTs is not totally dissociated. And on the basis of these relationships, one can predict that reducing the prostate volume would have a minimal effects on small prostate and modest effects on enlarged prostates. Coming to finasteride trial, it's a randomized control trial with 895 subjects. Comparing the finasteride 5 mg, 1 mg and placebo, these are the inclusion-exclusion criteria. The results are the reduction in the prostate volume from 19% in a 5 mg group, 18% in 1 mg group, and 3% in the placebo groups. And 5 mg finasteride shows a better improvement in symptom score compared to placebo at a period of 1 year. No difference at 3 months. PROSTAR long-term plus study, which is a randomized control trial with 3,040 subjects. Comparison of finasteride in the placebo placebo, a period of 1 year. These are inclusion and exclusion criteria. And in this, there is a mean prostate size decrease for a period of 1 year. And there is no reduction thereafter. Hence, this is the rationale why we prescribe this 5 apparatus inhibitors for a period of 1 year and no use after 1 year. And there is a significant improved flow rate compared to placebo. And finasteride reduces the risk of needing surgery by 50% and prevents AUR by 57%. And this acute retention or surgery, the placebo group needed 9% more compared to the finasteride group. Hence, these are the EU guidelines. Our subject who's asymptomatic completely, who's incidental, find out the enlarged prostate, who is not at all having symptoms, straight away fall into the category of watchful waiting, whether with or without lifestyle modifications or education about that condition. And regarding this EU guidelines are concerned, there are strong recommendations that conservative management can be given with mild to moderate, which are minimally bothered patients, and the lifestyle modifications can be taught along with treatment. Coming to pharmacological treatment, alpha blockers should be prescribed for men with moderate to severe LEDs, which are bothersome, and 5-alpha reductase here, as per EAU guidelines, is more than 40 ml prostate with the moderate to severe LEDs is a criteria for prescription of 5-alpha reductase inhibitors. Coming to AUA guidelines, here we get here also almost there is the same bothersome moderate to severe LEDs. Alpha blockers are needed, and whereas 5-alpha reductase inhibitors are necessary if with bothersome LEDs along with 30 cc of prostate. Here American Urology Association says 30 cc. Then now what can be done in this? My subject who is an incidental find out in ultrasound, who comes to me with a lot of anxiety, feeling that something is inside. And my role is need to give a proper education for him, like prostate gland is a normal, where it is located, what its function, and we need to reassure him really that it's not a disease and it's a natural phenomenon of aging and it grows along with us, and we need to tell him really that what the symptoms he develops with that, and we need to educate him what symptoms we need to observe, and if he neglects those symptoms and what complications he may get landed. So we need to tell him, and we need to tell him to come to a periodic monitoring. If he develops symptoms, come or ask for follow-up. And lifestyle, no harm in getting lifestyle advices. So I advise, hence he is not asymptomatic, huge restriction of fluid in plenty of liquids during the day, and restriction of fluid after 9 p.m. is enough. And double voiding along with time voiding every 3 to 3.5 hours maintains his bladder health. Coming to follow-up, as per EU guidelines, initial follow-up should be at 6 months. And after 6 months, if he is fine, stable, and he can be called an annual follow-up every year, we need to compare IPSS and renal functions, uroflow. We need to see the curve, how it is compared to the previous curve, and we need to see whether there is a more residual compared to. We need to compare all these parameters compared to the previous one. And my take-home message is medical management is only for bothersome LUTs. Treat the LUTs, not the size of the prostate. No LUTs, no tablets, no capsules. Size alone doesn't matter. Just wait and watch. Ask the guest to visit again. And in this, I feel some more studies are needed. I thank all the audience for your patient listening.
Thank you. Thank you, sir.